Hello and welcome to our webinar today. Which product is the best for which patient? Presented by Ms. Professor Dr. Ricarda Bauer. It's a pleasure for me to have you all here again. Last webinar was really successful, and now there is step 2. From my side, some informations regarding this webinar. During this webinar, you all will be muted. When you have a question at Ms. Professor Dr. Ricarda Bauer, please feel free to ask this question on the button. Here there are questions that you can ask them, and these will be answered normally at the end of this presentation, or if these are urgent questions that are totally fit to the slide, which is on the screen at that moment, I will slowly interrupt the presenter and will ask this question. Here you can see it again. This is the easiest way, because if everybody is not muted and interrupt the presenter, it will be very annoying for him. So I hope everything is fine. You will enjoy the meeting or the webinar. This webinar will be recorded, and after this presentation you can see it online. We will send you the link for this webinar. And so I'd like to welcome Ms. Professor Dr. Ricarda Bauer, and as you say, Professor Ricarda Bauer, the stage is yours.
So thank you very much and good afternoon. Dear colleagues, a warm welcome from Munich. I try to share my screen. Can you see the screen now?
Yes, perfectly. Perfect. Thank you.
Very good, thank you. So these are my conflicts of interest. So the main risk factors for male stress incontinence is the radical prostatectomy. Everybody of you know this. And thus incontinence is still the most feared side effect of the radical prostatectomy. Early stress incontinence is in the first month after surgery is up to 87%, and persistent after 1 year up to 20%. It depends on the center. High volume centers achieve a persistent stress urinary incontinence rate of below 5%. In addition, many men suffer from urge incontinence. Good thing is mostly self-limiting, only in cases where the patient already suffered before the radical prostatectomy. Very often the urge symptoms persist even after 1 year. In general, men below 50 years have a significant higher continence rate compared to older men. And everybody who deals with post-prostatectomy incontinence man knows urinary incontinence in man has a very strong negative impact on the quality of life. Of course, we talk today about surgery, but first line therapy is and should be in every case the physiotherapy. When we talk about post-prostatectomy incontinence, we have to look at the male sphincter system. I call it sphincter system because it's not only one muscle, it's really a complex system with striated muscles, with smooth muscles, and we have longitudinal parts, we have the circumferential part, and all if there is it's necessary that all parts really interact together. Otherwise, the patients suffer from incontinence. And very often you see in these patients after post-prostatectomy incontinence, they have no urine loss during rapid increase of pressure, for example, coughing or sneezing. And in addition, they can interrupt the stream without any problem. And when you do the cystoscopy, you see that they are able to close completely the sphincter. This happens because the striated sphincter parts are completely intact. The problem in very high number of cases is only the smooth muscle. And due to the disturbed smooth muscle function, we have a reduced basis continence. And so when the patient or the muscle gets tired, then the stress incontinence appears. So when the patients do some physical activity, do some gardening, for example, then it starts tripling. In some cases, we have a more complex situation, for example, in patients after surgery of the benign prostate enlargement, patients after radical prostatectomy and radiotherapy, and also sometimes after radical prostatectomy with a direct sphincter lesion, anastomotic dehiscences or additional anastomotic resections. Then we see in these cases a direct sphincter lesion and a combination of smooth and striated sphincter dysfunction. So I already told you the conservative therapy, the physiotherapy is really important and should be the first line therapy. So when the patient does the sphincter training, it is important to train the slow switch muscle fibers. So it makes no sense to contract open and close and open and close. So it's really important that the patient focus on the longer contraction of the sphincter. So it is really important that the patient have a professional guidance. The effect of biofeedback and electrical stimulation is really controversial. There are studies who say it has a positive impact, and there are studies without positive impact. Drug therapies, there's nothing available. Of course, there's the duloxetine, but it's not approved for men. You can use it, but only as off-label use. And I use it especially in patients in the early post-op period, when the patients are really frustrated by their incontinence and they started the physiotherapy, but they see no effect until now. So normally it takes 6 to 8 weeks that the patients see really significant effect of the physiotherapy. And for this waiting period, I use in more frustrated patients the duloxetine. The study says the combination of the sphincter training and the duloxetine improves the early incontinence the best. So it makes no sense to use only the duloxetine. It's important to combine the physiotherapy with the duloxetine if you use it in your patient. If the patient suffers in addition from urge symptoms, then we also should treat these symptoms with anticholinergics or beta-3 agonists. So now the question is, when is the perfect timing of surgery? So the stress incontinence should be persistent despite sufficient physiotherapy. Steady state, in my opinion, is very important. I always ask the patient, what was 4 or 6 weeks ago? How was the incontinence? If the patient tells me 6 weeks ago I used 5 pads, now I use only 3 pads, then you should ask the patient to go forward with the physiotherapy. And in addition, patient's demand. If the patients has some leakage, but he does not suffer, so there's no need to do a surgery and discuss with the patient the surgery. Here you can see, if you already participated in session 1, then you already know this nice figure. You see here that all started more than 50 years ago with the Scott sphincter in 1972, 1982, the A.M.I 800 was introduced, and over the decades, a lot of new systems were introduced. The newest one is here, the Volco system, adjustable. It's only at the moment available in South America. But now the question is, we have a huge amount of products, but which product is the best for my individual patient? So first of all, we can ask the guidelines. So this is the European guideline. They tell us we should offer the artificial sphincter to men with moderate to severe stress urinary incontinence. We should offer non-adjustable the transobturatorial slings to men with moderate to mild prostatectomy incontinence, means the advanced XP sling. And there is limited evidence that adjustable male slings can cure or improve stress incontinence in men. So my first problem is, I don't know what means mild, mild to moderate, or severe, because there is no definition that really is used worldwide. So if you have a look at the studies, continence, incontinence, mild, mild to moderate, severe, in every study it means a little bit different thing. So this is my first problem. So I think we should go a little bit more in the detail and have a look at the systems and how the system works, and how which complications and problems can occur. So we have the artificial urinary sphincter. You already saw it's established since decades. The A.M.I 800 is really old but proven. We have new models, adjustable systems like the Victor and the Sapphire. And however, it's a large, for the patient, technical device. There's no natural micturition possible. The patient has always to use the pump to empty the bladder. There's a deactivation necessary after implantation, and there's a deactivation necessary before you put in a catheter or you have any urethral manipulation. However, we see nice continence rate, and in addition, you really have to look very in detail what continence mean in each study. So here they talk about social continence and completely continent, completely dry. Completely dry means no pads. Social continence means in general up to 1 pad. So with the artificial sphincter, you can reach here in these huge meta-analysis social continence in 80% of the patients, and completely dryness in about 45% of the patients. However, you need manual dexterity and cognitive skills for successful use of this system. These are some newer dates. It's the meta-analysis from 2023 with more than 2,200 patients with 19 studies. Here, the continence rate similar, 52% with no pads. Social continence, again, around 80%. So this is probably the success rate, the dry rate we can achieve with our gold standard, the A.M.I 800. You have to know that the artificial sphincter will not survive as long as the patient will survive, hopefully. So the survival rate of the artificial sphincter is about 5 to 8 years. And the main reasons to have problems in the meantime are infections, mechanical failures, and urethral atrophy. So in my experience, it is really rare that you see an infection without erosion. So my experience is, if you have an infection, you should really rule out that you have an erosion. In 90.9% of the cases, you have an erosion, and the erosion causes the infection. But in my opinion, in my experience, the early killers are the unexperienced surgeon who really do the preparation a little bit close to the urethra, has no real perforation, but is really close to the urethra. And then over the first weeks, you see an erosion. And the catheter without deactivation or big catheter, long catheter time, these are unfortunately problems that occur not really seldom. So I explanted last week a patient who had a hip surgery with a catheter for 2 weeks because he has a problem during the hip surgery, and it was not proper deactivated, and 20 Sharia catheter was placed in, and now the patient had an explantation due to the erosion. So this is something I can expect after catheterization without deactivation or with a huge catheter and long catheter stay. What can be achieved with the new systems, with the adjustable system? So adjustability really sounds very interesting, especially in patient who has a little bit dribbling, only social continence. Maybe I can add some fluid in the system and make the patient really continent. So this is the outcome data of the Victor with 96 patients, follow up 3 months to 5 years. And you can see here that the urine loss in the 24-hour PET test is, this is baseline 640, after 3 months 100 cc's, here after 5 years 250. So it's not really the very perfect results, and not really results the patients are normally happy with this. The adjustments are very often it's 0 or 1 adjustment. Only in the beginning, in 70 patients, we see 70% of the patients, we have 2 or more adjustments. But always keep in mind with the adjustments, it makes no sense to adjust, because at some point you have such a high pressure of the urethra that you will see the erosion. So in this study we had 6% erosions. Explantation rate was 14%. There was no significant risk factor. However, it was really over the long run a small number of patients. So I expect with the all new adjustable sphincter system the same risk factors as we see it in the A.M.I at 800, like for example the radiotherapy as an important risk factor. And here is the first e-sphincter. This is the sphincter I'm looking for since really long time. The electronic sphincter, maybe in the future with an app, but here at the moment it's something like a remote control from the colleagues from France. And it's a prospective multi-center study with 6 patients, 1 year follow-up, and the PET test dropped from more than 400 to 26 gram. There was 1 postoperative hematoma, no erosion, no explantation, no infection. And this is, in my opinion, a really important feature. It is possible to reduce the pressure during the night. And maybe we have some devices in the future where we can reduce the pressure during the home office day and increase the pressure when we do some gardening or have some sports activities. Unfortunately, the system is not yet marketed, but I hope for more data and someday the chance to use electronic sphincter also in my patients, because I think this is the future regarding the artificial sphincter. When we talk now about sling systems, we have 2 types of sling systems. It's the adjustable systems, and we have the functional systems, adjustable systems, the Argus, the Atoms, and the Remix, and functional, the advanced XP sling. So first of all, I would like to talk about the functional sling, the advanced XP. So we can really discuss for hours, but probably we have a multifactorial mode of action for this type of sling with a support of hypermobility of the urethra after radical prostatectomy, an increase of the functional urethral length due to the repositioning made by the advanced XP, and in addition, a venous sealing effect. So everything comes a little bit more up in the more correct position. What can we achieve with the advanced XP sling? This is our multi-center study. We were very strict with the definition of continence. So only continence cured a patient with 0 pads, and in addition, they had to do a 24-hour pad test, and only with 5 grams or less, they were cured, and 0 pads in addition. So, and there we can see after 60 months, a cure rate from around 60%. The complication, this is very good, are really rare, mostly mild. There are no long complications, so complications are not really an issue. We have to think about it in these type of sling. However, there are some patients who fail with the advanced sling, and here I would like to show you some risk factors for failure. And these risk factors are really important to know for the patient selection. There are more than 5,600 patients included in these analysis, and a high risk for failure had patients after radiotherapy with a high urine leakage in the 24-hour PET test. Unfortunately, there was no really a number how high the leakage had a risk factor, but high urine leakage is a risk factor. In addition, if the patient had a history of incontinence surgery, history of urethral structure, and detrusor overactivity, and a negative repositioning test. If you don't know what it is, I will show you later on what it means. They have a moderate risk for failure, and age and weight were not a risk factor in these patients. So very important to keep in mind for the patient selection. So the ideal patient for the advanced XP seems to be a patient with stress incontinence after radical prostatectomy, without radiotherapy, who had no urethral procedures. The ideal patient has an increase of the incontinence during the day, during physical activity, has no nocturnal urine leakage, and when he goes up to go to the toilet, the patient comes dry to the toilet. During the sphincter evaluation, he has no sphincter defect, a mobile posterior urethra, and the positive repositioning test with a functional uterine length of at least 1 centimeter. I will show you later on what does this mean. So this is the ideal patient, and in these patients, you have really good success rates. No pads in the pad test, 5 grams or less in the 24-hour pad test, about success rate of about 60%. But we see in the long run that the patients suffer in some cases from recurrent incontinence after the advanced 6P. And you see here how the incontinence increases again over the years. If we look into the data, then we see that severity of the incontinence has a major impact on worsening over time. In this study, there were not only ideal patients included, so maybe we have better results in these patients, but I think we should talk about lifelong sphincter training with our patients, because the advanced sling is only in the tissue. There's no fixation, nothing. So if the muscles, the pelvic floor muscle, everything comes down a little bit, so probably the advanced sling also comes down a little bit. And if the sphincter of the patient loses a little bit of contraction, then probably the support of the advanced sling is not strong enough anymore. And so as we talk with our female patients after slings about lifelong sphincter training, maybe we should also do this with our male patients. Now, what about the adjustable slings? I already showed you the guideline recommendation. There's limited evidence that adjustable male slings can cure or improve stress urinary incontinence. Is this really true? Look at this statement. With over a decade of published results associated with atoms now available, this adjustable sling device has positioned itself as an effective surgical option. And I would say all the studies and all the data we have for the atoms speaks really for itself. So let's look at the data. This is a meta-analysis with more than 1,300 patients, 20 studies. Here, there's the continence rate of 67%, 90% of the patients improved. Patients need 2 to 3 adjustments to achieve these results. And the risk factors for bad success in the atoms is radiotherapy and severity of incontinence, more than 6 pads as stated in the analysis. However, my problem is I don't know what 6 pads mean. Is it only a small pad? Is this a huge pad? Is this a diaper? I don't know. So, but we can say and we can state severity has a negative impact on the outcome of the atoms. So let's have a look at the long-term results. Once again here, 3 years, and there we saw in this study that patients with more than 250 grams urine leakage had a significantly higher risk of failure, and due to the failure of explantation. And also previous surgery for stress incontinence has also a higher risk for persistent stress incontinence and followed by explantation. So it's important that in the adjustable sling systems, in the atoms, radiotherapy matters and the urine leakage matters as well. So also very important for patient selection. So we talked about the radiotherapy. What is the outcome in patients after a radiotherapy? And you can see here, we had really a lower continence rate for only 21% compared to 51% in patients without radiotherapy, and of course a higher PET usage after surgery. In addition, explantation rate, mainly due to failure, was higher in the patients after radiotherapy. So we have really to have a look at the patients and select the patients properly to have really good outcomes with the atoms and happy patients with the atoms. What about complications with the atoms? We have, and this is important to discuss with the patients before the surgery, we have postoperative paresthesia in about 1/3 of the patient. This is normally in the area, in the scrotal area, in the penis, and this can really, patients can really suffer from this, and they really have to know it upfront. In addition, patients can suffer from perineal pain, in some cases, they have persistent pain. In addition, we can have wound infection, port infection. Here you see a picture of an erosion of the port. So we have to counsel on our patients probably and tell them that there are some more risk factors, especially compared to the advanced sling. However, not every patient is eligible for the advanced sling, and then you have to discuss other options with the patients. When we talk about the atoms, then we also have to talk about the implantation and the implantation technique. So the classical implantation technique was just to open the skin and the tissue and free the muscle and implant straight away the atoms. We saw, thanks to Fabian Kreiser's data, that a more proximal implantation with dissection of the centrum tendineum and really needle insertion as deep as possible, we see better results. You can see here the paper Fabian presented a few weeks ago at the EAU in London with very good results with the more proximal implantation. And I know it's a little bit more time, it's a little bit more difficult to implant, but it is worthy to implant it more proximal because you will see better results and you see more happy patients with the more proximal implantation. So the advantage of the adjustable sling system, the atoms, it's not technical implant. The patient is able to void normally. There's no need to use a pump. There's no need for deactivation after surgery, no need for deactivation before catheter or anything else. It is no perfect residual sphincter function mandatory, like we have it in the Advanced XP. So we can also implant it with very good results, especially in patients after TOP, laser, or whatever. In these patients, we see with the advanced sling really bad results. In addition, it is possible, even after years, to do some adjustments, and there's no cognitive and no manual skills required for proper function. So for the patient, it's really easy and straightforward, and there's nothing they have to take care of it. And even if you have patients with bladder tumors where transurethral resections or cystoscopy necessary on a regular basis, it's no problem at all. You can take out the fluid and do the procedure, and then adjust the system again during the procedure, during the surgery. So you don't have the hassles like you have it in patients with the artificial sphincter. Bulking agents sometimes are really on vogue to use. Patients sometimes ask for bulking agents. Here you can see the current publication. It says they are less effective than other treatments, and this is also what the guidelines say: do not offer bulking agents to men with post-prostatectomy incontinence. What about the PROACT balloons? Also a procedure, very straightforward, very simple, but also here do not implant it in patients after radiotherapy, and the implantation is associated with high failure and complications rate. The good thing, it's really easy to explant the system, but in my opinion, we have much better systems available, so we don't really need the PROACT balloons anymore. But now the question is, what for whom? What is the best patient for which system? If you ask the patient, what does the patient want? The patient wants to have this small, tiny sling, meaning the advanced sling, because it really looks small and very attractive to the patients. But you already saw how the ideal patient looks like. The problem is it will not work in every patient. So we need a patient selection. And during the patient selection, it's really important to have a really good medical history. Not only what happened to the sphincter itself during the surgery, but also, I call it always special questions, like when can you store the urine? Tell me a situation that you normally lose the urine. What happens during the daytime? Can you interrupt the stream? What happens when you cough, when you sneeze? What happens when you go up in the morning or in the night to the toilet? Can you go to the toilet dry, or you lose the whole bladder filling, or only a partial bladder filling? These are really important questions to have an idea of the residual sphincter function. And when the patient had an additional radiotherapy, it's always important to hear or to see if there was a worsening of the incontinence, was there a de novo urgency, especially if this is a patient where you don't want to put in an artificial sphincter, and you maybe think about an adjustable sling system, knowing that the outcomes are not as good as with the artificial sphincter, but the patient is more eligible for the adjustable system compared to an artificial sphincter. In addition, I always do a uterine cystoscopy. Of course, you can do a perineal ultrasound to see how the sphincter works. with the ureterocystoscopy, I can see the tissue, the urethra, how is it atrophic? How is the elasticity? I can see, in addition, strictures, of course, pathologies of the bladder, and I do a sphincter function assessment. And in the end, I fill up the bladder until the patient tells me, no, it's really full, to assess the functional bladder capacity and see if there is still a good bladder capacity, or if there's maybe already a problem, or maybe an overactivity problem, and the patients need some additional assessment, like urodynamics, for example. And during the sphincter evaluation, I do the repositioning test. Some call it also elevation test or GOTSI test. It's all the same. So we use a surrogate cystoscope. We stay distally of the sphincter, and the first step is I ask the patient to contract the sphincter by himself, and then I can see, is the patient able to contract the sphincter circumferential? Is there maybe a closer, more like a mouth of a fish, or is the patient not able to close the sphincter? And then I have a first idea. Then I use, to be honest, in real life, I don't use here the sponge. I use my fingers, and I go parallel to the anal canal and below the bulbar urethra, and I put some mild mid-perineal pressure for repositioning the posterior urethra. And you don't need a lot of force. It's really mild pressure. And if the sphincter is, if the test is positive, then the sphincter contracts by itself. The patient is relaxed. So you see it here in the middle of the picture. The cystoscope in all the three pictures is always at the same spot. And we see the sphincter closes by itself without the patient contraction. So, and then I ask the patient once again, like in the beginning, to contract the sphincter again. And then the so-called sphincter, the functional sphincter zone, cooperative zone, closes. And you can see here all this part is closed. Maybe it's a little bit difficult to understand. This is why I will show you now a movie. And in the movie, you will see first, I will do the repositioning. The patient is relaxed, and then the patient contracts the sphincter. So that's me. That's me. I close the sphincter, and you see concentric closure, and now the patient contracts in addition. And when you really hold the cystoscope loose, then you can sometimes really feel that the patient pushes you out, and sometimes the patients really tell you, oh no, I have much more force than I had before. And this is a positive test. So it really closes over a long zone, and this is a patient. This patient will have a very good result after the advanced XP sling. And now I will show you patients that are not the right ones for the advanced sling. This is a patient, he had a radical prostatectomy, he had a radiotherapy, he had several resections in the anastomotic region. And already in the first picture, you see it looks really weird. And the tissue is not really pink, it's more white, more atrophic. And when I do the repositioning, this is the picture in the middle, I can see, I can close it, but there's a little gap here in the middle. And when I ask the patient now to contract the sphincter by himself, he's able to close this little hole, but the functional sphincter zone is, there's nothing, yeah, there nothing closes. So this is a patient from the early beginning, he had an advance, the patients failed, and now he has an artificial sphincter. And this, to be honest, is the perfect treatment in the beginning for a patient like this. This is a different story. This is a patient after transurethral resection of the prostate. Already here in the first picture, you have the feeling there's something wrong. Then after the repositioning, I see the nice sphincter defect in the upper circumference. The patient is able to close, but the coaptive zone is again 0. So also this is a patient, he's not a perfect patient for the advanced sling. He needs another treatment. I talked earlier already about the radiotherapy in patients for the advanced and patients for the adjustable slings, but also in patients for the artificial sphincter, radiotherapy is a risk factor for erosions later on. And so I would like to show you this study because it's always the discussion, how long should we wait after the artificial sphincter, after the radiotherapy with the implantation of the artificial sphincter? And this is what the study tells us. 280 patients, 1.7 years. I know this is really a long time. To be honest, I never wait such a long time. Normally I wait at least 3, in my opinion, better 6 months after the radiotherapy. But we have to keep in mind that the current study says 1.7 years is the best waiting time for the artificial sphincter after radiotherapy. And I would like to mention one additional problem. I already told you I've assessed the bladder, the functional bladder capacity during the cystoscopy. Why? I would like to see patients and to find out if there's maybe some detrusor problem in the patients. Of course, you can ask the patients about urgency. If they are more incontinent, they are not able to tell you. You can ask the patients about nocturia. This is an indication, yes. But if you see during the cystoscopy that there's only 200, 250 cc's bladder capacity, or maybe the patient, the bladder really presses out the urine during the cystoscopy, then probably there is detrusor overactivity. And in these patients, it really makes sense to do a urodynamic evaluation upfront. And this study shows it makes sense because patients with an idiopathic detrusor overactivity before post-prostatectomy surgery, slings or artificial sphincter, they had a higher risk for failure. It was not significant in general, but especially if we look at the slings, then the results are really much worse in these patients with detrusor overactivity. So if we have patients with this problem, proper patient counseling is necessary, of course, but I recommend to treat this problem upfront before we implant a sling or an artificial sphincter to reduce the post-operative problems. If the patient has shows the problems after the surgery, or shows still the problem after the surgery, then of course additional therapy like antimuscarinics, beta-3, or even botulinum toxin is necessary. And it's, in my opinion, important to inform the patients upfront that there maybe can be a problem. So in my opinion, in my experience, one surgical implant is not enough to treat men with post-prostatectomy incontinence properly. So for me, the ideal advanced XP patient is a patient after radical prostatectomy with no urine leakage while lying in the bed. He has no sphincter defect. He has a worsening of incontinence over the day. During physical activity, he had no radiotherapy. He has a mobile posterior ureter and a functional ureteral length of at least 1 centimeter. So adjustable slings, we can treat patients who lose a little bit more urine, who also lose a little bit urine during the nighttime. The patient should not really leak a lot when he goes to the toilet. He should be able to interrupt the stream. The functional ureteral length is not important in these patients. The type of the prostate surgery is not important. So you really can use this system with very good results also in patients after TOP, a laser, or whatever. And of course, you can use it in patients that are not really suitable for the artificial sphincter, or they not want to have the artificial sphincter because they are kind of afraid of this system. However, you have to counsel the patient that in this situation, the results will be lower than with an artificial sphincter. And the artificial sphincter is the perfect system for all the patients with radiotherapy, with a stress incontinence, with high volume, complete incontinence, with really huge defect of the sphincter. These are the patients who should go for the artificial sphincter, but because only with these devices the patient will have good results. And in addition, when I see a patient and when the patient tells me it's incontinence situation, I have some points they are really red flags for me, and we should keep in mind. So with the advanced XP, you need, of course, the perfect residual sphincter function. If the patient has a radiotherapy, it's a red flag. When he tells me I lose the urine during the night, red flag. I'm not able to go to the toilet when I get up in the morning or during the night, red flag. The patient had no radical prostatectomy, red flag. So the advanced XP, I need really proper patient selection. And in addition, the patient should have some rest, physical activity rest after the surgery, that the healing process is not interfered. And adjustment is not possible. For the adjustable slings, I have to keep in mind that radiotherapy and the size of the sphincter defect has a negative impact on outcome. A rigid atrophic urethra, red flag. High or complete urine loss during physical activity, red flag. It's not a good candidate. If the patient has no chance to interrupt the stream, or you loses more than 50 cc's during the night, red flag. The size of the implant, of course, it's bigger, like the advanced XP, but it's now no technical implant. After surgery, the patients can suffer from paresthesia, can suffer from pain, and of course, permanent perineal discomfort can happen in some patients. And like for the artificial sphincter, it's the same recommendation, only use saddle for the bike that is called a prostate saddle, that is open, that they don't sit directly on the cushion or on the cuff for the artificial sphincter. And of course, compared to the polypropylene Advanced XP, infection rates are higher due to the silicone. For the artificial sphincter, it's important that the patient knows there's no physical micturition, there's a large technical implant, there's a need for deactivation before any ureteral manipulation. The manual and cognitive skills are really necessary for proper function. Bladder capacity below 200 or even below 250 cc's can occur with high problems, especially urge incontinence. There's a risk of erosion and ureteral atrophy, and the lifespan of the implant is about 5 to 8 years. However, I have really nice amount of patients now with the artificial sphincter implanted for 10 years or longer, and the system still works properly. But the patient has to know that some reduce are probably necessary. So this is what I would like to show you at the end. Very often it's a funny question, but there is a study, so it's probably not really a funny question. So patients very often ask me, with the artificial sphincter, is it possible to empty the bladder still standing at the toilet? And what does the study say? What happens after 1 year if the patient empties the bladder standing up or sitting? He will do it also after the implantation, 1 year after the implantation of the artificial sphincter. So the toilet behaviors will not change after implantation of the artificial sphincter. So no worries, you can go to the toilet as you like. In conclusion, so postoperative incontinence has a significant negative impact on quality of life. So patients really suffer from post-prostatectomy incontinence. First-line therapy, of course, is physiotherapy, but surgery is always indicated if there's a persistent and stable situation and the patient's demand of a treatment. If you make a decision for implant, then you should always look at the best ratio of continence rate and complication, and consider always the individual patient wishes and demands. If we really understand the pathophysiology and we really do proper diagnostics, we have a very high chance for successful treatment of our patients. And metastatic disease, metastatic prostate cancer is not a contraindication for the surgical treatment, because under the treatment options we have today for metastatic prostate cancer, patients survive for a very long time. And in my opinion, there's no need for these poor guys that they have to, in addition to the metastatic prostate cancer, a severe incontinence. Thank you very much. And now I'm looking forward for your questions.
So thank you very much, Professor Dr. Ricarda Bauer. We have some questions. How long do you wait from the surgery to the implantation?
From the for the prostate surgery. For
Yes.
me, it really depends on the severity of the incontinence. If the patient comes to me in my office and the patient still leaks everything after 3 months, and I check if the proper sphincter contraction, and he did already physiotherapy and nothing happens, then we should discuss with the patient some treatment, because I do not expect any significant improvement of the incontinence. If the patient comes to me after 6 months and he still uses 2 pads, and he tells me 3 months ago I used 6 pads, then the patient should go again, do some physiotherapy and try to train the sphincter function. So it really depends, is the situation stable, yes or no, and how much is still the leakage.
Okay. Thank you very much. And how many patients?
Sorry, there was a recommendation in the guidelines some years ago. We should wait for 1 year. I think that's not really fair for really severe incontinent patient. If the patient really leaks everything after 6 months, he will leak everything after 1 year. So why should he suffer?
Okay. And one question is, would you consider implanting an ATOMs for a patient with history of radiotherapy and only mild, moderate incontinence, 200 cc in 24 hours?
It depends how the sphincter looks like, how the urethra looks inside. Is it really pink with a good blood supply, or is it really atrophic? Is it more white with bad blood supply? Is the patient able to contract the sphincter completely, or is there some sphincter defect? If everything looks perfect, I would say, like without radiotherapy, of course I implant adjustable slings, ATOMs in these patients, but of course the studies say the outcome is a little bit worse. But for 200 cc's, an artificial sphincter is quite an overtreatment. So if this patient is not happy after the implantation, you can still implant an artificial sphincter, but normally with 200 cc's, with this medical history, the patient will be quite happy.
Okay. And
of course, you have to tell the patient that they should not expect desert dryness, yeah, no drop at all.
Okay.
And if you compare a 70-year-old man with prostate, they are very often also not completely 100% dry.
Okay. Okay, thank you. And an ATOMs for a patient with reconstruction of bladder.
Say it again. Reconstruction of the bladder.
Yeah,
maybe
so
it's a cystectomy with a neobladder.
So the question was
a cystectomy with a neobladder. No. This is a patient with incontinence with a neobladder. They need an artificial sphincter because they have no muscle contraction, and they need a really low pressure system.
Okay.
Maybe we can have some additional information regarding this question.
Okay. And one other question is A.M.I the only system you can use or which works directly after the implantation?
You can use also the Ergo sling. It's also an adjustable sling system, of course. It's the adjustment is not as easy as with the atoms. With the Argus, you need an incision to open the skin and go down to the we call it washers, to do the adjustment. So it's not a port system we have with the atoms. So in the past, when I started with adjustable slings, I started with the Argus, and then I changed to the atoms because it's more easy, the adjustment, and more comfortable for the doctor and also for the patient.
Okay. Thank you. And one last question about the cushion of the atoms. Some patients complain that it's too big and they feel it. Has the same thing happened there?
They, of course, it depends on the filling. If you fill up the system with 25 cc's and the patient has not really a lot of fat in the perineal area, then of course you can feel it.
Okay, what would you recommend? How many milliliters would be the best opportunity for the first step?
So so the first filling is during the surgery, and during the surgery you fill up with 10 cc's, and then you put 10 cc's in, and then you let flow back in the syringe the overpressure. So normally during the implantation you have 6, 7, maybe 8 cc's in the system, and then the patients, I see the patients again after 4 weeks, and then at this time the patients do some normal activities and there's no swelling left. And then if the patient is dry and happy, nothing to do. And if the patient still leaks some urine, then I start with filling up with 3 cc's. And then you can fill up 3 cc's on a regular basis until the patient is happy. But if you fill up 6 or 9 in addition to the initial intraoperative filling, and that changes nothing, then it makes no sense to fill up to 25 whatever. Then the system was not the perfect one for the patient. But normally you see with 3 cc's in addition to the intraoperative filling, you see a significant improvement. And you should not go, this is the recommendation, and should not go over 25 cc's. Of course, I saw already patients with 40 cc's, and this is like a tennis ball, sitting on a tennis ball. And I don't think it's very nice to sit on a tennis ball, and it's not the perfect solution for this patient.
Okay. Perfect. Thank you very much.
But of course, if you have a very thin patient, then you have to discuss before the implantation that maybe the patient really feels some discomfort because there's no fat or nothing, and he really sits directly on the cushion.
Okay, and that can create problems or discomfort. Yeah. Yes, yeah. I understand. With Professor Dr. Bauer, it was a pleasure to join or to listen to your presentation today. I think we've got a lot of information, and also a very big thanks to the audience, because only with you with your question, you make it very well. Thank you very much. I hope we see us all again in September with our next webinar. And I wish you all a good night. So if you have any question, please feel free to contact us. And thank you very much. Have a good night.
Thank you. And I wish you a lot of happy patients with the implants.
Thank you very much. All the best. Bye.